Yes, thank you very much, Dr. Gasimova. Yes, now today we want to share our experience on the microvascular decompression, more on surgical aspect of trigeminal neuralgia. And a lot greetings from the Turkmenistan, from the Ashgabat, all the participants of this Zoom conference. So, microvascular decompression for trigeminal neuralgia, Ashgabat Expirence. The microvascular decompression is a type of surgery which the compression of cranial nerve is removed, and the cranial nerves can be compressed by the vessels, vascular malformations, and the thickened arachnoid layer or tumors. This compression problem is often seen in trigeminal neuralgia firstly, secondly on facial nerve and glossopharyngeal nerve, and accessory nerves. That's a literature information. Introduction. We know the microvascular decompression operation is that we divide it into two parts, until the Janetta time and after the Janetta time. Until the Janetta time, the microvascular decompression operation was done by so many types that I don't want to mention about it. It will take a long time, and just want to talk just about when it begins to do from the posterior fossa. Professor Walter Dandy, he started to do this type of surgery with the posterior fossa approach, and after the Walter Dandy, Dr. Gardner continued his work, but at the end, in the 1968, Dr. Peter Janetta performed the first successful microvascular decompression for trigeminal neuralgia using a small Teflon pad and separate the offending vessel from the nerve. And here is a role of the Peter Janetta is he especially popularized this type of the surgery in the world, and he wrote a lot of paperworks on it, and that after his works, this procedure takes a name as a Janetta procedure or Janetta operation. So now we want to present our cases since 2020 until this time, and this is now over the 200 cases in our clinic. The microvascular decompression, when we do it, this is general information, just who don't achieve adequate pain relief through pharmacological therapy. We call this group of the patients drug resistant, and who experience intolerable side effects from the medications. As we know that just the only anticonvulsant group of the medicaments treats this trigeminal neuralgia, and as we know, the carbamazepine is the main medicament for treatment of this disease. Studies have shown that MVD provides long-term pain relief, approximately 17–19% in patients with a classical trigeminal neuralgia. It is one of the effective surgical operation in our practice. Success rate, despite its high success rate, the recurrent pain occurs approximately 20% after the 10 years of the surgery. Recurrence is often due to the recompression by the blood vessels by scar tissue formation. Teflonoma, we call it like this. And the main complaints of the operation: cranial nerve deficits such as hearing loss, facial weakness, and bleedings, intracranial hemorrhage, and hematoma formation, aseptic meningitis, inflammation without infection, brainstem injury, rare but very seriously complication, and secondary infections. This is general complications, and overall complications rate is low, less than 5%. As you know, the three branches of the trigeminal neuralgia, ophthalmic branch, maxillary, and the mandibular branch. Most commonly, V2 and the V3 comes together. Patients complain. Patients describe the pain such as very sudden, severe electric shock-like, often lasting from a few seconds to several minutes. This is a pain that which is humankind experience it very severe pain, the most severe pain, and the patients are suffering from this pain very strongly. The pain is typically unilateral and follows the distribution of the trigeminal nerve branches V1, 2, 3, and pain episodes are frequently triggered by touch, chewing, speaking, brushing teeth, exposure to cold air. Diagnosis is very simple. Just talking with the patient, that you can see the face of the patient when you come the patient with the trigeminal neuralgia. The patient history is very important. What we do here, especially for the patients, we don't do the surgery if the patient has a pain for the short time. At least we wait 2 years. The pain should continue for 2 years, and during this time he should try all the conservative options, and if all the conservative options get a fail, at the time we offer the operation. Key diagnostic feature include this is a kind of the pains, paroxysmal sudden severe electric shock-like pain, and the pain comes when he is eating, when he's chewing, and when he's brushing his teeth, when he's talking even. And there is a intra-extraoral trigger points when they touch the face inside of the mouth, they get the pain to start. And these are the clinical, and we can get this information by asking to the patients. Additionally, for medical report, we can get this diagnostic with the MRI, contrast medium, with the spatial regime, or CT scan with the contrast, and it's a posterior fossa on the pons region where starts the trigeminal nerve. We can identify the blood vessel and the nerve conflict. Differential diagnostics, we should do it with the secondary trigeminal neuralgia and some post-herpetic neuralgia, atypical facial pain, migraine pain, or some stomatological problems or craniofacial problems. Now we see here is MRI. This is a trigeminal nerve, and this is brainstem, as you see, and artery loop. This is MRI view, and this is a inter-op view. This is a left side trigeminal nerve, and then vessel conflict. Treatment. That, as we mentioned, there is a pharmacological therapy. The first stage, we start with this anticonvulsant group medicaments. If it gets fail, that the surgical option is we offer the patients. And surgical options include the physiological operation, microvascular decompression. Additionally, ablation with radiosurgery, percutaneotomy, radiofrequency ablation, and balloon compressions are also some options for the treatment of this microvascular decompression. Especially ablation procedures we offer the patients with the older age, and if the patients are not so good at with the long time surgical operation time, if we can't tolerate it, it's a time we offer for this type of patients the ablation treatment. Indication for surgery: failure of the medical therapy, classical trigeminal neuralgia, recurrent pain, patients younger than 70 years old, and the patient's reference. Why microvascular decompression? What's the beneficial ways of the microvascular decompression is the curative approach, address the root neurovascular compression. It is a rather than the symptoms, high success rate, provides long-term pain relief. And if we compare it with the ablation therapy, it makes a very 2-3 times longer, because after the ablation, the patients come with this pain after the 3-4 years. And nerve preservation doesn't damage the trigeminal nerve, preserving normal facial sensation. As you know, after the ablation, we get the sensory loss of hemifacial region. And durable outcomes, lower recurrence, and compared with the ablative procedures, the microvascular decompression, we call it golden standard. These pictures that we get from the Professor Gadol's pictures. We do it also in this position, lateral park bench position, and here is a anesthesiologist area, and this is a nurse, scrub nurse, and the assistant and the surgeon. This is a real view from our operation room. Here is a type of the incision we do it. This is very simple and makes it very easy to do with the craniectomy or craniotomy. For that reason, simple straight incision is quite okay. This is head position, and for the anatomical remark, here is sigmoid sinus and transverse sinus. All are we mark it with the marker, and this is a mastoid tip, the mastoid groove, and approximately we make the pre-op radiographical line. And after the incision, the main target is to find the angle between the sigmoid sinus and the transverse sinus. This is this is an important point. And we enlarge the craniectomy with drilling to the sigmoid sinus side, and the upper to the transverse sinus side. And here is some surgeons says that we must see the sigmoid sinus and the transverse sinus really clear, but we try to just preserve this sinus and to see the just line of the medial lateral line of the both sinus is quite okay to make the craniectomy. Not so go far. And then we collect all the small bones, and as Peter Janette says, that to closure the mastoid area, air cells with the bone wax, or wax in, wax out. We must perform it. Now we want to present our case. Firstly, I want to mention about the craniectomy area. As possible, we try to make it a very small craniectomy. It is 1/2 centimeter. And opening of the dura, curved or fascian opening of dura, we perform it. Then they lift up and take the dura. And the first stage is releasing of the liquor. And just we see firstly vestibular cochlear and the facial complex nerve. It is, we can see here the behind of the vestibular cochlear nerve, there is a facial nerve. And spatially, in this area of the vestibular cochlear nerve area, we find arterial inferior cerebellar artery, and there are perforances of the artery which brings the blood for the pons. And why we start to open the arachnoid layer from the region of the vestibular cochlear nerve. It is very important. It is very crucial because we can open it here very easily. If you want to start it from the region trigeminal nerve, we can sometimes injure the vessels. For that reason, we must start this arachnoid dissection, sharp dissection from the region of the vestibular cochlear nerve. And we try to preserve. Here is, it must be mentioned, this is a petrosal vein or dandy vein. This is trigeminal nerve. And some surgeons say that absolutely it is necessary to coagulate and cut it. But we try to preserve it because these veins, sometimes there are some variants of connection of some veins, and they bring a lot of superficial cerebellar vessels, blood. For that reason, as possible, we try to preserve it. And this is a very sharp dissection of the arachnoid layer. Just here is, we work just a little bit rashly because we make the video 2-3 times accelerated. For that reason, that you can find it a little bit quickly. But it requires to manipulate the nerve very softly, gently. This is crucial because this is a region, very small area, and you should be very slowly, you should be very gently. And here we do the dissection of arachnoid layer, sharp dissection. And trigeminal nerve is decompressed. Decompressed from the artery, as you see here. This is the offending vessels, the complex of superior cerebellar artery. This is a region, root entry zone. The pain comes mostly from the root entry zone. This region must be taken for attention, but all the way of the nerve must be decompressed. This is Teflon implant, and the nerve is decompressed. This is irrigation, and as you see, the nerve The endovein is preserved in Teflon and trigeminal nerve. And now here I want to just mention about the type of the compressions. Mainly that we see the approximately 80% of compression comes from the artery, and 15% is come from the vein, and the 5% is come from arachnoid thin or without any compression or like this. And for trigeminal neuralgia, and we see a lot of time the compression is with the superior cerebellar artery, and sometimes inferior cerebellar artery, or with the veins, as you see here, some variantes. What we do that for the closure of the after the procedure, we collect all the bone where we do the craniectomy, and put it back. Why? Because this is more physiological and anatomical. We collect all the bone and put it back and closure it with the some hemostatic materials. It can give some sponge or surgicel. You can close it, cover it, this piece of the bone. Here is, we see the after the operation, 6 months after the operation, the bone that we put it here is fixed and closed the craniectomy area. And our experience for 5 years, it's more than 200 in one center. And the comparison between the genders, we see it more than on women than the men. It is approximately 1.5 or 2 times more on the woman. In comparison with the lesion side, it is the right side and more than the left side. The reason is still unknown, but some anatomical variants maybe can be the reason of this right side that we see it more than left side. That someone says that internal foramen where starts the Meckel's cave is a bit narrow than the left side. They say that this is a reason, but we don't know how it's right. That just that we heard and we read from the some literature information. The comparison for the age, the patients are older than 50 years old that we see this trigeminal neuralgia. And prefer to note that just want to mention about the information in younger patients with neuralgia. Lesion is caused by mostly by osteoma or thickened arachnoid layer. That in the next slides we will show it. Unique case. All the cases, over the 200 cases, the one patient appeared with a bilateral neuralgia, operated on both sides. After the surgery, on the both sides, the pain is disappeared and without any complications. Just one case. And now we want to mention about some rare case that in our operations. Camel hump. What is the camel hump? That it is a small percentage of the case are classified as a secondary trigeminal neuralgia resulting from space-occupying lesion, such as tumor. One extremely rare cause in osteoma. This is a camel hump. It was even when they call it camel hump, in Pittsburgh clinic, when the Janet teams performing this procedure, they saw that in posterior fossa on the petrous bone they found osteoma, and they called Peter Janetta to see this operation, and he came and just looked at this osteoma and called it's like a camel's hump, and after this it was a camel hump. This is like a nickname of the osteoma which grows from the petrous bone. This is our case. Here is, you see, osteoma, and this is trigeminal nerve. This is vestibulocochlear complex. And how we remove this osteoma? This is with the kerosene ronger. We remove it. And after removal, we can do the manipulation easily. Here, is decompression of trigeminal nerve. This is offending vessel, and we put here Teflon. From the both sides, here on the right side there was an artery, and from the left side there was a vein, and the trigeminal nerve is completely decompressed. This is second came with the osteoma. This was a very small, and we use drilling. Really, this is a very with a high risk manipulation, but if we don't make it thin, the kerosene can't take it out. For that reason, we make it thinner with the drill. And if you pay attention here, after the drilling of the osteoma, the nerve is decompressed, and the main cause of the compression was the osteoma in this case. And I want to mention about the dolichoectatic basilar artery. The majority of trigeminal nerve cases are the compression from the smaller mobile vessel like a supracerebral artery. However, but the critical etiology involve compression from ectatic, dilated and an elongated basilar artery, condition known as a vertebral basilar dolichoectasia. This is some kind of the vasculopathy, and if the diameter gets more than 4.5, we call it dolichoectatic basilar artery. And in MRI, we can see easily here is enlarged and a displaced basilar artery on the right side here. And what's interesting here is here is a compression is all the cranial nerve from the trigeminal and facial nerve and the caudal group nerves. But this symptom makes only pain on the left side of the patient with trigeminal neuralgia symptoms. Here is we see now video of dolichoectatic basilar artery compression of trigeminal nerve. Just here, I want to remark of coagulation of the petrosal vein. Why? Because this is a very seriously decompression. The basilar artery very mobile, and during the procedure, maybe we can get some dangerous bleeding. For that reason, just before the decompression of the basilar artery, we coagulated the dendy vein, petrosal vein, for the preventive aid. we coagulate and cut the vein, and now we see the basilar artery here. This is trigeminal nerve. This is basilar artery. And completely remove and displace the basilar arteries is impossible. As you see, here is even some perforants are seenable. Here is some perforants. And for that reason, just we wanted to put the Teflon between the trigeminal nerve and the basilar artery. This is basilar artery, this is the trigeminal nerve, and the dissection of all the arachnoid layer. And here is very interesting what, because still there is a compression. The basilar artery is compressing the nerve, but just we put the border, just we dissect the nerve and dissect the nerve with the contact with the basilar artery. And it works, it worked. After the operation, there was no pain. All the pain is gone. And this is also one of the very interesting cases, and approximately from the 200 case, we have a 5 or 6 cases with the ectatic basilar artery compression. And just I want to talk about some complications of the procedure. During the procedures that here we see from the right side, we got pontine ischemic stroke after the operation, and the patient get right side hemiparesis and the facial palsy. And the facial palsy gets recovered after the 2 months, and the hemiparesis gets better than before, but it stayed around from the 5 to 4. Now, conclusions and discussion section that just we want to summarize and give us some key information after the 200 operation. In trigeminal neuralgia, the pain appears more often on the right side. Trigeminal neuralgia occurs more frequently in females than male. Trigeminal neuralgia often present after the 5th decade of the life. Trigeminal neuralgia in younger patients often associated with osteoma or thickened arachnoid layer. In rare case, trigeminal pain can occur or without vessel conflict. Partial preservation of arachnoid layer, placement Teflon beneath the prevents displacement of the Teflon. Performing a small craniectomy and closing craniotomy with the patient's own bone is practiced at a more anatomical and physiologically appropriate. Thank you for your attention, all the participants. If some questions.
Sorry, I was muted. Okay, so thank you so much, Dr. Nurgeldi, for a very comprehensive presentation. It was very nice and very detailed explanation, and it was it even made so much sense for us medical students to understand. With that being said, as the moderator, I'd like to begin the Q&A session by opening the floor. I see that we have a few questions in the chat. So the first question is, thank you for your great lecture. We know that the closer the burr hole is placed to the junction of the transverse and sigmoid sinuses, the easier it becomes to access the cerebellopontine angle. In this context, do you routinely use neuronavigation to optimize your trajectory? Dr. Efecan Erişken, İKCE Neurosurgery Department.
Thank you very much, Dr. Efecan Erişken, for the question. This is a strategy of the operation. This is the main point of the operation, to find the trajectory entrance of cerebellopontine angle. And in our cases, over the 200 cases, no one is done by the neuronavigation. All is done by only just with the anatomical landmarks. The main landmarks are that, as we mentioned, there is a mastoid tip, mastoid groove, and the approximately region of the transverse sinus and the sigmoid sinus. For that reason, and there is sometimes we follow the emissary vein, which is show as a point of connection of the sigmoid and the transverse sinus. For that reason, yes, sometimes it can be difficult to find the angle of the two sinus, but that we don't use the neuronavigation for this type of the operation.
Thank you. We have another question from Dr. Erişken. What is your opinion about the use of preoperative lumbar drainage in these cases?
Yes, some authors says that before the dural opening they use a lumbar drainage, but we don't use it. We don't use it, and no one time. And why? Because we do the craniectomy and then dural opening, and we release CSF from the posterior fossa, from the cisternal magna, or near the caudal group nerve. And it is quite okay to reach the region, and we don't do the additionally lumbar CSF drainage. Really, sometimes with some patients there is a problem when the cerebellum is if there is swelling, that the very small hole, craniectomy hole, can be not so easy to reach the cisterna magna, but that we don't use the lumbar drainage. We follow this way, and despite of some cases, some difficulties, we use the CSF release from the posterior fossa.
Thank you. The next question is from Dr. Mehmet Seçeralanya. Have you ever had a patient with trigeminal neuralgia associated with multiple sclerosis or Chiari malformation? What is your approach to these patients?
That as I mentioned, that here is I said that before the operation we follow the patients for 2 years, and during the 2 years we send the patients for the neurologist, because sometimes we get patients with the trigeminal neuralgia plus multiple sclerosis. The symptom is same on the multiple sclerosis. The pain is like a classical trigeminal neuralgia symptoms. For that reason, we do MRI routine MRI and spatially MRI for the posterior fossa to find out some vessel relationship or to look for the offending vessels. And then during this time, we try all type of the investigations. Neurologist looks, and then we control the patients. And for that reason, we want to minimize to make the mistakes with the multiple sclerosis. For that reason, we have no cases with the multiple sclerosis neuralgia and also Shire malformation.
Thank you. A remark from Dr. Selim Bozda. Thank you for this detailed presentation. And one more question from Dr. Erishkan. Do you think previous radiosurgery makes subsequent microvascular decompression more difficult?
Unfortunately, we don't use radiosurgery or any additional manipulation for the trigeminal neuralgia. What we do pharmacotherapy, and someone tries some gamma knife, cyber knife treatment, but we have no case that we do the microvascular decompression after the radiotherapy. And I think it doesn't make some difficulties.
Okay. Another remark from Dr. Orhan Mehmetkhanlı. Thank you for a wonderful presentation and sharing your experience. And the next comment is, thank you for your presentation.
Thank you very much, Dr. Orhan.
Do you use any glue for sticking Teflon? Do you use any adipose tissue instead of Teflon? Dr. Sherif Hajiliyev from Turkmenistan. I hope I read it right. Was there an internet connection issue?
Okay, I can hear you now.
Okay. Were you able to hear the question, or should I repeat myself?
Yes, okay. We don't use the glue to make the Teflon fix it, but that as you know that we try to decompress the trigeminal nerve, all the arachnoid layer, and from the surrounding tissue and the vessels, if possible, absolutely free from any.
Yeah, I guess you were having connection issues.
Yes, it is okay.
Yeah. So if it is possible, would you be able to repeat the last part of your answer because it was cut?
Okay.
Yeah, sorry for that. Okay. So moving on. What is your recurrence rate in the event of recurrence? Do you use surgical methods such as coagulating the nerve with low-grade bipolar by Dr. Mehmet Seçer?
Yes, we have some recurrence from the operation. In literature that it is written commonly the recurrence comes after the 5 years, but that we have some cases.
Yeah, I guess the speaker is having connection issues again. Yeah. Okay, technical difficulties. Welcome back, Dr. Saparow. If you could unmute him, that would be great.
Okay, do you hear me?
Yes, we can now.
Okay.
You were
Recurrence,
cut in the
yes.
last part. Yes.
Recurrence rate is from the 200 operation, we have a 6 operation with the recurrency. And what's interesting in literature that they mention about the recurrence comes common after the 5 years, but we have a recurrency after the 2 years, and one is 3 years. The last one is from the 1.5 years later. And we have done second operation with the same approach from the same site. And what's interesting, we couldn't find out the new vessel offending. Just there was a Teflon in its place. And we guess and we think it is a reason of the recurrence comes from the from itself, Teflon, and it calls the Teflonoma. The Teflon materials has some adhesive characters, and sometimes it fixes with the nerve and gently, and maybe it can make a pain to make it recidive. For that reason, we remove the Teflons, which stays, and then make a massage of the nerve. We don't do the coagulation of the nerve, or sometimes some people, some surgeons do the resection or semi-resection of the nerve or intersection of the trigeminal nerve, but we don't do it. Just we do the massage of the nerve, and it works. What is good that from the second operation, all the patients get pain-free, without coagulation, without intersection, or without semi-section of the nerve, just with the massage from the root entry zone up to the foramen of the starting point of Meckel's cave.
Thank you. The next comment is from Dr. Razrahim. Thank you for a wonderful presentation. Is there any kind of difference between living in different geographical regions?
Thank you very much, Dr. Oraz, for the question. Unfortunately, that we can't say something right now, because that I think it doesn't matter region, because we get patients all over our country, and I think it is almost the same by the regions, and I don't see the some geographical region that gets some more patient or not like this. I think it is almost the same.
Okay. I guess this was the last question, and it seems that we have reached the end of our Q&A session. Once again, we sincerely thank Dr. Saparow for sharing his experience and expertise with us today. And thank you all for joining us, and we look forward to seeing you again in our upcoming Izmir online neurosurgery sessions. Have a great evening, everyone.
Thank you very much. And all greetings from Turkmenistan, from Ashgabat. And I want to say that Thanks for the Izmir online neurosurgery course, and especially for Dr. Professor Hasan Kamil Sucu and Dr. Selin Özdağ. Thank you very much. Have a nice night.
Thank you. Good night.
Bye-bye.